Okay, we are live here. I am just going to hop over to Facebook, make sure it is indeed streaming. It takes a few seconds. But the good news is there's always people anxiously awaiting the program to start from all over the world, which is exciting.
That's wonderful.
And there we are. And people are already waiting for us, so let's not delay it any further. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and LACNets program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I'm your host this episode and every episode, and I'm a filmmaker and a writer by trade, and I've been working with CCF for over 10 years now. I think we started around 2011, 2012. And in that decade plus, we have created, I couldn't even guess how many videos, at least hundreds, maybe thousands. Lots of video content, patient-centric documentaries, treatment-based videos, live video series like the one you'll watch today. Lots of videos that are all free for you to look into if you are a part of this net journey, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, if you're new to the journey, or if you're new to this show specifically, I want to welcome you to this community. I feel very proud of the community we've cultivated here within Luncheon with the Experts land, we could call it. But the overall net community is incredibly, incredibly supportive, I have noticed, in this 10 years working alongside the community. So I say that to say, the value you're going to get from today's show is one, the information and guidance from our guest expert, but two, and I would argue equally as valuable, the shared experiences and shared stories from within the community, from other patients, from other caregivers, from other support group leaders. So if you see people in the comment section, they're starting to chime in now, saying where they're signing on from around the world. We always love to see the reach that we have. I encourage you to introduce yourself, embrace the community, and I promise you it will embrace you back. Now, before we get started, we always want to thank our sponsors, Ipsen Biopharmaceuticals, for their support of Luncheon with the Expert. We simply couldn't do the show without their support, but we do have this disclaimer from them, and that is that the opinions expressed by the guest, as well as the questions asked by the audience, that's you all at home, haven't been created or suggested by the sponsors of Lunch with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in today's presentation. So, and here's the crux of it, audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so like with disclaimers or any legal language, it's a little wordy, but the point is we don't know your specific case. We're going to hopefully give you some general guidance and advice and hopefully answer some of your questions, but take that advice and that information home to your home team, which does know your unique case, and collectively you all can make the best plan and path forward for yourself. One more announcement that I mention every week. This project, Lunch with the Experts, is now one of the products that the merger between CCF and LACNets has created, and a lot of the new guests that we've had this year has been because of our partnership with LACNets, which we love. But another amazing thing that we are able to provide is the support line through LACNets. And if you want to visit that for anybody needing support, patients, caregivers, whomever, you can fill out a questionnaire at lacnets.org/support line. This is for anybody affected by neuroendocrine tumors. Speaking of which, our guest today is one of those guests that we have met through LACNet. So welcome for the first time to the show, Dr. Bhavana Konda. How are you, Dr. Konda?
Hi, Rain. Thank you. Thank you for the introduction. I'm very well, thank you. And thank you to CCF for this opportunity today. And thank you, Rain, for moderating. And thank you to all of our patients who are joining on.
Absolutely. Yeah. We appreciate you being here. You and I did clarify that you're not necessarily off, but you are signing on from home today. So we appreciate you making extra time for us while you're at home. And I'm sure that people in the audience do too. For those that may not be familiar with you, what is the role that you fill in this net community we've alluded to? Where do you work? What do you do specifically?
Sure. So I'm a medical oncologist, and I joined the Ohio State University 9 years ago. Um, so I am the section chief of neuroendocrine tumors and endocrine-related cancers at the Ohio State. We are a group of three medical oncologists here, and we have a great multidisciplinary team. We have a huge patient base. We've had our neuroendocrine tumor program for over 2 decades now.
Wow.
My mentor was Manisha Shah, Dr. Manisha Shah, who retired a couple of years ago. And yeah, and we are blessed to see our patients and have a great team to support us.
Absolutely. What is the percentage of your patients that are net patients?
So our patients, about 60 to 70% are neuroendocrine tumors, and the rest are thyroid cancers and adrenocortical cancers.
How did you get into this particular cancer specifically? Did you always work with net patients, or was there a journey to that?
No, truthfully, in fellowship, during our training, these are rare tumors, right? So during our training, we don't see as many rare tumor patients, but there's a huge need. And I've always been attracted to endocrinology in general. It's been fascinating, and rare tumors in particular because of the unmet need. Common cancers get a lot of the limelight, get a lot of funding. There are plenty of clinical trials, but rare tumors, neuroendocrine tumors, is where there has been a lot of progress of late. But years ago, there wasn't much,
Yeah.
and and I really wanted to make a difference, and in this group. So that's why I joined.
I love to hear that. I mean, you share that with a lot of the doctors that we have on the show that see the gaps, perhaps see the opportunity to make an impact with their work in this disease, and that's one of the reasons why the net community is so strong. I believe, in my opinion, is that you genuinely have people who are out there to make a difference working with this, and you also alluded to another fine point. I've worked in, as I said, with net tumors, at least in this, this position for over 10 years. So I've seen the activity that's happened. Talk to me a little bit about, because I think you said, or you've been in this position for 9 years. Is that correct?
That's right. I've
But
been
you,
I've been treating patients with NETs and endocrine cancers for 9 years.
okay, got it. Okay, perfect then. So about 10 years as well. So talk to me about the progress that you've seen. I know in the past few years we've had a flurry of activity, but from your perspective, when you joined this community and started serving these patients till now, what strides have you seen that excites you?
Amazing progress, Rain. I mean, it's unimaginable, right? Because when I joined, there was no gallium PET, there was no radio labeled isotopes, there was some atorvastatin analogs like octreotide and lanreotide, modest benefit. There was everolimus, modest benefit. And then you really want more. You want, if you want to make a difference, you want to see prolongation and survival. You want to see good tumor shrinkage. You want to see scans that are actually able to show disease. And so since I joined, well, gallium PET came into being, PRRT came into being. We
Right.
were one of the first sites that opened ludotate therapy to patients here in the US. We used to send patients to Europe when I first joined,
I
and
love it.
and it's amazing that we're able to give our patients this treatment here in the US. Um, and several clinical trials have opened in combination with PRRT, not only in combination with ludotate, but also the more upcoming alpha emitter therapies, which are the early data is very encouraging, and we are bringing in a couple of these studies to the Ohio State, and so that's a very exciting time. More recently, like 4 days ago, The results of cabozantinib in neuroendocrine tumors was published in a leading journal, New England Journal of Medicine, and that was a registrational study, which means it was done with the idea of getting the medication FDA approved, and it's that, and the results were encouraging, and it adds to our portfolio, our expanding portfolio of treatment options for our patients.
Absolutely, and we may get questions about that today because it's obvious it's been of particular interest this year and the past few months. Folks at home, I see your questions already coming in. Great job. We will start to take some of those. So keep sending those as you can. Try to ask them in generic chunks if you can, and not a lot of information. It's very hard to feel that all at the same time. If Dr. Konda needs more information, we'll ask for it. But yeah, go ahead and start sending in your questions. I appreciate everyone so far, and we also have someone in attendance who is your doctor, Dr. Konda, Shauna. So she says hello. Okay. Let's go ahead and start taking some questions from Dina from North Carolina, where I am. Hello, Dina. This is a two-part question. Can lanreotide cause joint pain, and does it act as a steroid? Because I've gained weight since I started using it.
That's a good question. Lanreotide in general, medications have several side effects in general. The most common ones typically are, some amount of abdominal bloating, gassy sensation, some joint pains I have seen, not super common. Weight gain, I typically we do not see. It's not a steroid. So typically you wouldn't see side effects related to corticosteroid production or anything like that. You can see a pancreatic enzyme insufficiency symptoms, where your stools can look light colored, greasy, sometimes loose. Sometimes sugars can go up. So those are the typical ones. Gallstones you could see, but those are the more common symptoms.
Got it.
Side
Hey,
effects.
thanks, Dina, for your question. Let me know if you have any more. And everybody at home also, just remember that today is Friday, which we typically have the shows on Thursday. So just in case anybody who wanted to be in attendance has also forgotten and is not here, you can tag them in the comment section if you're on Facebook. YouTube, I think, does it as well. Or you can share this video with them. If there's anybody that you haven't seen say hello in the comments that you know would want to be here, do me that favor and remind them that the show is going on. We still have plenty of time. Speaking of YouTube, we have Sarah coming from over that way that says, "Hi, I'm in Michigan. I had a tumor in the upper lobe removed from the airway of my left lung last year." This is a very general question, broad question, but we'll try to help. The question is, what are the chances I have more tumors or will see a recurrence? And I know that's obviously hard to predict, but let's just talk about the general concerns with this is a lung net.
That's a very good question. So it depends on a lot of factors, right? So first and foremost, it would depend on the pathology report. So it would depend on, okay, what type of carcinoid or neuroendocrine tumor is this in the lung? Is it a typical lung carcinoid or is it an atypical lung carcinoid? Typical lung carcinoids tend to have a more favorable prognosis. Atypical tend to be a little more aggressive. It depends on, is this tumor, what how are the when the surgeon removes the tumor, the pathologist looks at it under the microscope to see how fast are these tumor cells proliferating on there, and because that gives us an idea as to how aggressive these tumors are. So we look at the Ki67, which is the proliferation index of the tumor. We look at the mitotic count. We look at whether what's called necrosis within the tumor or not. So all of these give us, how are the margins after resection? Was all of the tumor removed? Are there tiny spots? Are there tumorlets within the pathology specimen? So all of these give us an idea with regards to recurrence. So I'd say it's very variable. It really depends on a lot of factors. And it's also important, therefore, to keep a close eye on these tumors. We typically For our lung neuroendocrine tumors that have been resected, we follow patients for a total of 10 years because these tumors can recur over time. And, you want to be absolutely sure that you are cured. And to say that we want to we give a total of 10 years before we discharge the patient.
Got it. Thank you. And thanks for your question. Let me know if you have any more, and welcome if it's your first time. I don't think I've seen you ask a question yet, Sarah, so welcome. Let me know if I am incorrect in that. Next question comes from Diane. Diane says, I have carcinoid syndrome. I had surgery 3 years ago, took out 25 tumors in my small intestines and liver, and I've had carcinoid crisis 3 times. So I'm having a colonoscopy this year. The question is, could this happen during the colonoscopy?
That's a good question. And it could, it's possible. It would be important to know whether you are on a somatostatin analog such as octreotide or lanreotide, because that could help prevent these episodes from happening. So we usually, for our patients who are going in for any invasive procedures who have carcinoid syndrome, we typically give them this carcinoid prevention document that they can take to their doctor or proceduralist so that they know what to do before the procedure, or if you were to develop a crisis episode during a procedure. And typically, we usually have patients take a rescue shot before the procedure and tell the proceduralist to have octreotide on hand should you develop carcinoid crisis. But yeah.
Could we, for someone who might not be familiar with that, could we establish what carcinoid crisis is if someone's never heard that term?
Absolutely. So, carcinoid crisis is something that can be seen in patients with carcinoid syndrome. So, carcinoid syndrome, as you know, is, in patients with neuroendocrine tumors, these tumors can sometimes make certain proteins or hormones that can give rise to symptoms. And what are those symptoms? They're diarrhea, they're flushing, they could be wheezing, they could be palpitations. So, there is this whole plethora of symptoms which constitutes carcinoid syndrome. Now, in situations of stress, anesthesia, sometimes there could be this crisis like episode where the symptoms are now exaggerated. So patient, the blood now they're extreme. Blood pressure can go up significantly or go down significantly. Chest discomfort could happen. Lot of wheezing. So these are what constitute carcinoid crisis, and it's important to see if we could prevent these episodes, particularly in patients who we think could be prone to a crisis like episode. And those patients are typically those who have poorly controlled carcinoid syndrome to begin with, who are not on the octreotide or lanreotide shots, who have a high tumor burden. So these are the patients we worry, could you have a crisis like episode when you're going in for a procedure? And if so, what can we do to prevent it?
Got it. Thank you. I appreciate your question, Diane. From from Jolie. I think it's a patient of yours, actually. Jolie.
Yes, hi Julie, how are
Okay,
you?
Jolie. Yes, Jolie. Sorry, Jolie. Okay, so question from Jolie. If we did not get the gallium PET before the lung net was removed, and therefore don't know if our net had the receptors, how do you decide when to use the gallium PET to look for metastasis?
That's a very, very good question. Very good question. So that is very challenging. And that is why it's important to get these functional scans ahead of time. Now, lung carcinoids can be very tricky. The reason they can be tricky is they are, sometimes don't make these receptors and sometimes make these receptors in some locations and don't make receptors in other locations. What does that mean? So a patient can have a lung carcinoid where the tumor has the receptors in the lung, but then the disease in the liver doesn't light up on the gallium PET scan. So there's a differential uptake, right? So this is the challenge we see in general with lung carcinoid tumors. And many times I end up doing both a gallium PET scan and a regular, which is an FDG PET scan, because sometimes they are missed on one scan and then you see on the other scan. But to answer your question, if it was not done before, I think it's going to be tricky to know whether the tumor makes receptors or not. So our best bet is to follow with anatomical scans, which we would do anyway. Anatomical, when I say, I mean CT scans, MRI, and if and when something were to come up, then I would do a gallium PET scan to see if you make receptors. And if the and if it doesn't light up on a gallium PET, I'd get an FDG PET to see if it lights up there. So an anatomical scans would be our best.
Got it. Thank you. And thanks, Jolie. So we talked about side effects recently from lanreotide, I believe. Glenn has a question. What side effects can I expect from first treatment of Lutathera?
Good question. So Lutathera is actually very well tolerated. Now, when Lutathera first came into being in the US back in 2018, we had a huge list of patients waiting to get the treatment, and some of them were very sick patients. And who couldn't go to Europe, so we treated them. And as we treated them early on, all of us expert institutions learned a lot of lessons. And now we select patients for PRRT or ludotate therapy very carefully. So if you're already planned for ludotate therapy, that means your physician thinks you are a good candidate, which means patients who have tumors within the bowel, for example, who are symptomatic from it. I I shy away from doing ludotate therapy because there's a risk of bowel obstruction. In patients who have disease in the peritoneum, which is the disease lining the intestine that is painful, I shy away from PRRT because there's a risk of bowel obstruction. In patients who have a lot of disease in the liver, who already have abnormal liver function, there's a risk of liver injury, so I don't do it. But all of those, if you're already receiving it, all of these wouldn't apply to you. Now, what would you expect? You could have some nausea. It's mainly the amino acid infusion that you get to protect your kidneys prior and after the treatment that causes the nausea, and you get a nausea medication ahead of time, and you go home with nausea medication as well, typically. Again, many patients don't have it. There are patients who have it. There can be some fatigue. But most of my patients typically have been able to carry on their work after PRRT treatment. So there is fatigue. It's not intolerable. Other than that, you could have some hair loss. You could have some decrease in blood counts. That's why we check blood counts every so often to keep an eye on it. Now, in very rare circumstances, because there's always rare side effects, right? All medications will have rare side effects. Where what could happen? You could have significant decrease in blood counts, especially if there's a lot of disease in the bones, for example, right? Those are the patients that I'd worry about. Okay, could blood counts go down significantly, or a lot of disease in the liver? And I'd monitor the counts more carefully and support as needed. Very rarely, in about 3 in 100, 1 to 3 in 100 patients, there is this bad side effect called myelodysplastic syndrome that can happen with radioactive treatments in general. And that's where your factory, that makes blood cells, which is your bone marrow, gets confused and doesn't do its job. So it's not making blood cells like it's supposed to, and patients become transfusion dependent, and there's a risk of leukemia. But thankfully, it's rare, but it's something to keep in mind.
Got it. Thank you. And thanks, Glenn, for your question. Next question comes from Pam over on YouTube. Hey, Pam, welcome to the show. Pam says, I've not been diagnosed, but my doctor thinks I have carcinoid syndrome because I certainly have all the symptoms of it. So Pam's question is, will the 24-hour 5-HIAA always show if you have it? And then I can also add, what else should Pam and her doctor be looking for to confirm?
Yeah. So Pam, that's challenging. And these we come across these situations sometimes, and the reason it can be challenging is you have all the symptoms. It seems like carcinoid syndrome. Nothing shows up on scans, right? Like what's going on here? 24-hour urine 5-HIAA is a good test to see if if it's high, then it's a hint. But is it perfect? It's not. There are several medications that could cause could when you're taking it when you're doing the test could cause false positives. So it's not a perfect test in general. In patients where they have the classic symptoms but I'm not able to get an answer. I have sometimes done a gallium PET to see because if the gallium PET is negative and my 24-hour urine 5-HIA is negative and all my anatomical scans are negative, then it's highly unlikely, right? Like then I should, because also I want to make sure that it's not something else, right? So after I am sure that it's not related to neuroendocrine tumor, then I say, okay, maybe there's something else that should be worked out. But now there are some situations where very rarely I've had where I still keep an eye on patients just to make sure nothing is coming up, and I've done that. But in general, a thorough workup would suffice.
Got it. Thank you. And appreciate you being here and your question, Pam. Let me know if you have any more. Next question from Cindy. We're moving right along. Great questions today, everyone. Cindy says, I had 2 small intestine nets, lymph nodes, and nodes on the pancreas removed 1 month ago. My tumor markers are way down, no more flushing, but diarrhea is still uncontrollable. They're giving me a 2-month reprieve from lanreotide for healing. Diagnosed also with carcinoid syndrome. Fatigue is still high, but working on building strength. The question is there a general timeline for recovery? I am 70 and I live in a place where it's still very hot and humid. So again, kind of a broad, vague question, but what are the things that Cindy should be considering and hopeful for in terms of recovery?
Yeah. So it really depends on how expensive the surgery was and, how, whether there were any complications post-op. But typically, if it was, tumor debulking surgery, usually in several weeks, I'd say in about 4 weeks, there should be a significant amount of recovery, and you should start feeling back to baseline. And in fact, you should start feeling better than baseline because of the tumors that were making Carson syndrome were removed. You should see, making those hormones were removed. Those symptoms should be better.
Gotcha. Well, hopefully that helps, Cindy. Let me know if you have any other questions. Appreciate you. Folks, we are about halfway through already today. We're moving fast. If you joined us a little bit late or you just joined us very recently, this is Luncheon with the Experts at Carcinoid Cancer Foundation and LACNet's program. We are here today with Dr. Bhavana Konda, who also happens to have a lot of, we'll call them fans, perhaps, in the audience today that have been singing her praises.
Oh, my, you guys are so kind. Thank you.
They have been very kind. You can see for yourself in some of the chats. And I also wanted to make an announcement. We've had a question or two about lung nets today, and there is a very special zebra wedding tomorrow. We'll say. I mentioned at the top of the program that we do these patient-centric documentaries too. I've been doing those since 2018 with the foundation, and we still do a few of those a year. And I was recently in California on a shoot for our next one, which will be released in about a month or so. But this is with a young woman who was diagnosed with a net, and she had surgery a couple of years ago. And she's getting married this weekend, which is a very unique take. So the documentary is really about when you're at that transitional point in life, you've got the whole rest of your life in front of you, yet you've had this net, this tumor that you've been dealing with, that's a pretty tricky situation to navigate emotionally, psychologically. That's what we're looking at. So it is a great story of hope. She was a great patient to deal with, a great person to deal with, and you all stay tuned. I think that's going to be a really great film that you can watch in about a month or so. Okay, and there's plenty of those too. If you want to go to our library, we have those patient stories. On Facebook and YouTube, and you can go to the playlist and watch any or all of those. Back to the questions, we have Claire, or maybe on Claire's behalf, and also a lung net question. So they say, building on the earlier question on lung nets, do you have any advice that you would give for lung net patients with poorly differentiated, aggressive tumors that are not dotatate responsive, where they are told that they aren't candidates for surgery? Specifically, they have Mets, extensive Mets, including liver, bones, etc.
That's a good question. And it's a challenging situation too. So typically, poorly differentiated lung neuroendocrine cancers, we treat them typically like small cell lung cancer and large cell lung cancer. So I would follow that pathway. I think it's important to do tumor genotyping, which means, your tumor that was biopsied is sent off. There are several companies now that do this testing where your tumor is analyzed to understand the biology of the tumor better and to see what kind of driver abnormalities your tumor has, which means what are the abnormalities or alterations in the gene that are driving this tumor to grow, and are there any medications that we could have that we could target? Now, many times, honestly, we do not find the target. We do it for sure, though, because sometimes we do find an actionable alteration, and we don't want to miss that because even one additional treatment option is great. But typically, patients with poorly differentiated lung neuroendocrine cancers, like any other poorly differentiated neuroendocrine cancers, are treated very aggressively because these are aggressive cancers that grow quickly and we don't have time to waste.
Got it. Thank you. And actually, a second question there. I was told that diarrhea is the main determining factor for carcinoid syndrome. The question is that always the case? If many other symptoms are present, like flushing, etc., and I'm assuming not diarrhea in this case, then would you recommend testing for this?
Good question. Diarrhea is a common symptom, but it doesn't have to always be so. You could have just flushing. I've had patients who don't have diarrhea, who have just flushing, who have wheezing, particularly lung neuroendocrine tumor patients, because they make histamine, they have wheezing, and they have flushing, but they don't have diarrhea. So it's not uncommon. So I do not think there is any additional testing that needs to be done. If there's no diarrhea but there's flushing, it would still constitute carcinoid syndrome in the right clinical setting.
Got it. Thank you for your question. Next question comes from, pardon me, from Ruby. What is the best treatment for metastases to the bone?
Very good question, truthfully, and I wish I had a great answer. Now, metastases to the bone is very challenging. Why? And it's especially challenging in patients who don't have much disease outside of the bone. And the reason is all of the clinical trials that we do, right? We bone is considered non-measurable disease, which means you cannot actually measure the tumor when it's in the bone. Unless there's a little soft tissue component, you cannot measure. And when you cannot measure it, you cannot follow it, right? How do you know whether it's shrinking or getting better? There's no way to know because bone mets either show up like thickening, it's called sclerosis in the bone, or they show up as a little hole in the bone, which is called a lytic lesion. And there are times when you treat and the bone lesion looks more prominent, and you don't know if it's more prominent because of treatment or is it more prominent because it's growing inside. This is the reason why clinical trials do not include patients who have bone only disease, because there's no perfect way to assess bone. Now, how can you treat it though? typically radiation, if there's a bone met that is painful, I would definitely recommend radiation to that spot because it's very effective. For the most part, it's effective. PRRT treatment is also effective for bone metastases and pain. Again, this is more like clinical experience driven, not clinical trial data, because as I said, clinical trials don't assess bone disease because there's no good way of doing it. But do we know what the benefit of everolimus or PRRT is in the bone? No, we don't. And that's unfortunate. And I think there's a way. I think we need more research in that area to understand better and understand how to follow these bone lesions better. Because bones, as you know, bone mets hide well. They're not seen well on CT scans, right? So, and you can't do a gallium PET every 3 months, like so. It's challenging.
Got you. Thank you so much, and thanks for your question. We have a follow-up question from Sarah, whom earlier asked us about the net tumor. She had the upper lobe removed from the airway left lung last year. She was asking a question about recurrence. So, update says, I am seeing a net specialist next month, which is great to hear. What questions should I ask? My main goal, which is understandable, is to get peace of mind that I remain cancer free. So, meeting with net specialist next month. Where should Sarah start? What questions should she ask? She's had the tumor removed in her left lobe.
So I would ask, and I'm sure the medical oncologist will go over all this with you during their first visit. But the good questions to ask is the type. What type of lung neuroendocrine tumor do I have? Is this a typical lung carcinoid or atypical? Because what is the Ki-67 or the proliferation index of this tumor? Because then that gives you an idea about how aggressive your tumor was, how were the margins, how many lymph nodes were involved after the tumor was removed, like in the PAT specimen, because all this will give us an idea as to, how often to do your scans and do the surveillance, how long to do the surveillance for, and so on. It's also nice to get the big picture, which is, if things don't go as planned or if something were to recur, then what are my options? What are we looking at? That's the big picture. And then, of course, ultimately, we don't want recurrence. We want to be no evidence of disease for 10 years and be discharged. But it's important to know overall big picture in case there happens to be a recurrence, then what needs to be done. So then you're
Got it.
well prepared.
Thank you, Sarah. Hopefully that helps with your meeting next month. I'm glad you have that meeting. Let me know if you have any other questions. Question from Lynn. Lynn says, please offer any information on SBRT. Let's clarify what that is as well. What are the side effects, success rate, any of that, etc.
Yeah, so SBR, that's a good question. And SBRT is a good treatment strategy, particularly, in patients who have tumor in the liver. One liver lesion is growing, everything else is stable. It definitely needs a multidisciplinary discussion in tumor board with, the medical oncologist, radiation oncologist, interventional radiologist, surgeon, all sit together, look at your scans and say what's the best approach. Because we are thankful and grateful in that we have several treatment options. But we want to make sure we're using the best one in the right situation, right? So, but typically liver and lung is typically where we would use SBRT for. And it is an effective strategy. I've seen benefit in patients with liver mets or lung mets where there's one spot that's growing and we don't think we want to do a bland embolization. Not yet, we think it's too big for radio frequency ablation, things like that. But it's a very case by case basis and it's very important to have that multidisciplinary discussion to see what's the best strategy for you for your tumor.
Thank you, Len. From Terry, is the pump used anymore for octreotide therapy?
Yeah, it is. Thank you. But because of we've had so many successes with so many treatment options, we have not needed to use it that much. But in the rare patient who have really bad symptoms, we have done the octreotide pump, and it helps, because how many times are you going to inject yourself with the octreotide subcutaneously, and and despite being on the long acting injection, and yes, the short answer is yes, we still use it, not as much. So it is rare, but we do use it.
Got it. Thank you, Terry. Next question from Sean. Sean says, I have a genetically rare gene mutation that needs special considerations. I've had the syndrome, symptoms, and markers for many years, but they could not find the tumor or source until the brain metastases. I really do appreciate the recent research strides that are happening, and I've found that suddenly the sandostatin is actually doing the opposite of what it used to provide. Is this because they are generic or biosimilar products? Is this different? Can lung tumors normally show up in other locations or different places in the body because the metastases look like lung nets? Um, yeah, so lung nets are perfectly clear, but metastases in the brain look like lung nets. Does that make sense?
Yes,
Okay.
that's a good question, and I'm sorry to hear your journey. So it's lung nets can go to the brain, and though lung nets are one of the nets where I do brain imaging periodically, unlike for other neuroendocrine tumors where it's not common to go to the brain and the yield to keep doing MRI brains is low. That's not the case for lung mets. Now, how did they know? Question is, so from what I understand from the question,
Hmm.
there's disease in the brain, but no disease elsewhere. It's brain mets, and it looks like the brain mets came from the lung.
So the Sean says I've had the syndrome, symptoms, and markers for many years, but they could
Correct.
not find the tumor or source until the brain
Until
metastasis.
the brain mets.
Yep.
Correct. So how did they know that it probably started in the brain? It could be from the pathology report where, there are some markers that we look at like TTF1. If it's positive, then you think, oh, maybe starting in the lung. Then you do a chest scan and then there's no disease in the lung. So these are unusual and very challenging situations that can happen. It's not common, but it can happen for sure. And then we try to make, what would I do? So if the disease is only in the brain and nowhere else, then I would obviously, make sure the brain is completely treated. And typically the way that's done is by either stereotactic radiation or whole brain radiation, right? Like hippocampal sparing. So depending on the extent of tumor burden in the brain, or if it's one tumor, then surgically resect it and then keep an eye on it. Beyond that, I wouldn't, once the brain lesions are treated with local therapy, I don't think an additional treatment would make, I think I would just wait and see how things pan out. Like, still keep doing the CT scans, still keep doing the MRI brain. Octreotide or lanreotide, you could add to see if you could have some delay in progression. But I think beyond that, I'd probably not use additional options. Why? Because I do want to use my options when I really need them too, right? If there's progression despite local therapy, then I want some option to be able to treat you. So what would I do? Like temozolomide has good brain penetration, so that might be a good option to do temozolomide with capecitabine. It's off-label, which means it's not FDA approved for that indication, but there is data to support that it's helpful, and that would be a good option. Now, how would you know if it makes somatostatin receptors? Would be a gallium PET scan would tell us if the tumors make have somatostatin receptors, and if they don't, then PRRT would not be an option. And I said for lung carcinoids, they are very tricky. They could show up in, they may light up in some areas and not in the others, and you would want to do PRRT only when there is uniform uptake in all of the tumors. So also it would depend on how aggressive is that on your brain biopsy or surgical specimen. What is the Ki-67? How aggressive is this tumor? Is it a Ki-67 of 50% or is it a Ki-67 of 2%? Because that makes a huge difference on whether I would give IV chemotherapy or not, like
Hmm.
80% Ki-67 versus, yeah. So a lot of factors to take into consideration.
Gotcha. Thanks, Sean. I appreciate that, and hopefully that guidance is helpful. Next question is from Allison. Allison says, if you do not have receptors needed for some treatment options like lanreotide, are there more options to treat atypical NET lung metastases to the lymph nodes?
Absolutely. So even when there is need to start treating those, right? So because many times we wait and watch. And the reason, and it may sound surprising, you may be like, okay, I have disease, and you're waiting and watching, and the answer is yes, because maybe the disease is going to be stable even without me doing anything. So then why put you through the side effects of treatment, right? So, but if and when we feel, okay, I think now is the time to treat, like tumor is growing, then what do I want to do? So I typically divide treatment options into local treatments, regional treatments, and systemic treatments. So local treatment means if if there's a lymph node, it's growing and there's nothing else, and you can take care of it through surgery, I would go ahead and do that, right? Like that's surgery, that's a local therapy. Regional therapy is more like if that or local regional, I would say, is like an SBRT treatment or radiation treatment, right? Like if we think that that location is going to be too tough to do like a robotic resection, then radiation is one thing you could think about. But if it is, if it's more advanced, if local or regional therapies are not going to be feasible, and octreotide or lanreotide are not great options, even in general, the benefit is pretty modest. Even in, we know that even in patients with receptor positive disease. But everolimus is FDA approved for lung neuroendocrine tumors, regardless of their somatostatin receptor uptake. It can help delay progression of the tumor. It does not typically shrink the tumor much, but it could help delay progression of the tumor compared to not doing anything. So that could be one option for systemic therapy. That means treatment that goes everywhere. Cabozantinib is another option. Again, that's off label right now because it's not FDA approved, but the recent data suggests that it also, it has, it is one option that we have now added to our armamentarium because it can also help delay progression of the tumor. Now, capecitabine temozolomide is a very good option that I use often. It is again not FDA approved for lung neuroendocrine tumors, but there is data, retrospective data, to support that it could cause tumor shrinkage about 30% of the time. It could help delay progression of the tumors. So if there's bulky tumor where we don't think that surgery is an option, radiation is going to be too risky and morbid, oral chemotherapy is a good treatment option. So several options, even for disease that is just in the lymph nodes in the chest.
Thank you so much, Dr. Konda, and thank you, Allison, as well. Folks, we have 10 minutes left. You have had great questions today, so we're going to continue forward and try to get to as many as we can in those 10 minutes. Next one comes from Martha. Good morning and gratitude to you all. You as well, Martha. Is there any benefit to following a low amine diet if lanreotide is successfully eliminating overt carcinoid syndrome symptoms like flushing? Could lanreotide be masking the fact that potentially harmful vasoactive chemicals are still being released?
Right. So lanreotide, octreotide are very effective for controlling carcinoid syndrome. So yes, but I wouldn't call it masking, right? Because it is helping reduce those hormone levels and helping with symptoms. So great. So that's a win. Number two is when the hormone levels go down, these hormones like serotonin, for example, they can sometimes damage the heart valve. and cause leaky heart valves. That's called carcinoid heart disease. So this octreotide or lanreotide decreases that risk as well. So definitely, I would say that is beneficial, and I would do that. With regards to diet, there is no prospective data clearly to guide us in one direction or the other. Usually, my patients try, it's more of a trial and error as to what works best for them. For some patients, tomatoes cause a lot of flushing and they avoid that. For others, it's spinach. For us, so chocolate, wine, for example. So over time, patients can better understand what dietary choices they need to make so that the quality of life is not impaired by this diarrhea and flushing and yeah. So in general, plant-based diet is a good recommendation, but what choices in general would really depend on each individual patient.
Got it. Um, Thank you so much, Martha. Next question from Kat. In addition to oncology administering lanreotide 120 every 21 days, I've been prescribed octreotide rescue shots to self administer when I have breakthrough symptoms like heavy flushing, for example. The question is, what is the life cycle of this rescue shot? Is it minutes, hours, up to a day?
Good question. So the lanreotide, I think you meant 120 milligram every 28 days, right? Because we use it every 28 days, typically not every 21 days.
Okay.
But because its lifespan lasts for 4 weeks, typically. Rarely we've made exceptions, but now the rescue shot, typically we have done it every 8 hours as needed. So most times, it could benefit you for a few hours. So it's not minutes. It's a short acting injection, which means that it won't, it's not a depot injection that's going to last in the body for four weeks, but typically about 8 hours or so, you would expect to see benefit. Now, there are others where you may want to take it more often than that if the symptoms are quite disabling and they benefit from a larger dose or more frequent dose, but typically it's about every 8 hours.
Got it. Hopefully that helps, Kat. Appreciate your question. From Barbara, excuse me, treatment options for net tumor in lumbar spine that's causing a lot of pain.
Good question. I'm sorry to hear that. So typically lumbar spine, of course, I'm sure there were dedicated MRIs and CTs done to see, where the tumor is and whether the spinal cord is being affected or any nerves are being affected that's causing pain. Typically, again, it's a multidisciplinary approach between the surgeon and medical oncologist, neurosurgeon, and radiation oncologist, to see, is the spine unstable? Do we need to do a surgery to fix this and help with pain? Or is this something that can be treated just with stereotactic radiation to help control pain? So typically one of those two would help. And sometimes a combination.
From the friends and family of Claire, in your experience and observation, are there any lifestyle, like dietary, physical activity, supplements, are there any lifestyle choices that you've noticed that have been helpful to patient outcomes? And if so, do these differ for highly aggressive versus traditional dotatate active forms?
Good question. I think we need to research that more and do studies. They are a little tricky to do because they can be subjective, right? But while uh, I typically tell my patients, if you can do 30 minutes a day of brisk activity 5 days a week, that would be great. Whichever type of neuroendocrine tumor you have, if you can do more plant-based diet, if you can do meditation, these are the things that I feel, would help, but no amount of alcohol is considered safe in cancer in general. So these are the things, but now, have they been proven? For neuroendocrine tumors, no, it's more anecdotal, and studies will need to be done to see more, understand more. Um, but yeah, but that's in a nutshell.
Okay. I have a question from Gail. First time on this site or this show. Welcome. I've had several small nets in my stomach that are being watched by my endocrinologist with routine endoscopy every 6 months. The issue for me is that there's little information that gives any guidance, help, or hope dealing with ongoing nausea and discomfort, all centered in the stomach. I live an active lifestyle, but my weight is low. As traditional medicine has so little to offer, is it appropriate to seek help in non traditional medicine? Are there guidelines that will help me not to make things? It cuts off there. Do you understand enough of the kind of the question to
Yeah,
address it? You think? Okay.
yes, thank you for the question. So, uh, it would be important first to understand what type of gastric means stomach, right? Gastric neuroendocrine tumor you have, because there are several types of these, and the treatment is different. So if you're having several neuroendocrine tumors there and they're being watched, question is number one, is it just in the stomach, right? Like, is this a there are different types of gastric neuroendocrine tumors. There's a type 1, there's a type 2, there is the type 3, there's a antacid or proton pump inhibitor associated. So there are several. So it would be important to know which type it is to understand it better. But with regards to traditional versus also, I assume you've tried, ondansetron, nausea medications in general, and none of those have helped. Question is, what is causing the nausea, right? That would be important, because if it is or type 1 gastric neuroendocrine tumor, you should not have nausea. So that would not be related to the type 1. If it's type 2, there is high acid production, and that can cause nausea, vomiting, and diarrhea, and that's treated differently. So it really depends on the type. With regards to non-traditional methods, I do not have a good answer for you there, and if non-traditional, you mean like non-allopathic, I think it's a tricky zone to tread, because it's important to know that all of these touted over the counter products that or herbal medications have to be very careful with, because they don't go through the FDA, so not everything has to be reported on the label. So we need to be cautious. We don't know what interactions they might have with other medications. So I definitely chat with your doctor to understand better as to first of all, the type of gastric neuroendocrine tumor, and two, is the nausea really related to it?
Gail, if I just wanted to say welcome, and I appreciate you being here. I'm not sure if that got to all of your question, but something in your comment stuck out to me. There's little information that gives any guidance, help, or hope. I know you were asking specifically about ongoing nausea, but those are three things that we try to provide every time on this show. So I would just encourage you to come back. You can always send questions in between shows to lacnets.org/support line, and they can give you more guidance and follow up to your questions. But please, we're here every 2 weeks. That's exactly what we have the show for. So I would love for you to come back, and I appreciate you being here. We have time for one more question. Perry says, what treatment is available after 6 Lutathera treatments?
Very good question, because that's the max. Because even after 4, I would have said we could either do the alpha emitter studies, or we could do repeat the Lutathera for 2 cycles. But after 6, I think with regards to radioactive treatments, I think we are in a tricky zone, because at least most of the clinical trials with alpha therapies only allow 4 prior, or radioactive treatments like ludotate therapy, for example. But I would see what other non-radio labeled treatments do I have. So have I exhausted everolimus? First of all, do I need systemic therapy, or are these liver mets where I could treat with liver directed treatments like black embolization? Or if systemic treatments, then do I, do everolimus or cabozantinib? Or if it's a pancreatic neuroendocrine tumor, have I seen capecitabine temozolomide? So there are several options in the non-radio label section too. So I wouldn't be discouraged even if there's progression, if you've had 6 treatments and you've progressed, because there are treatment options.
Got it. Thank you so much. And that is our show. It is 1 o'clock on the dot here in Eastern Time. Dr. Konda, thank you so much. Incredible answers, very thorough, very thoughtful. And like I said, you already had a lot of fans in the audience. Folks, if you enjoyed your time, say thanks, Dr. Konda, in the comments. But I genuinely appreciate you being here so much.
Thank you so much, and it's been a pleasure, and thank you for having me.
Absolutely. Hopefully, we can have you back on the show soon. And thanks to you all at home. As always, we hope this program helped answer some of your questions. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. Finally, my name is Rain Bennett. I have been your host. Thank you for watching.